Welcome to PharmaDocs with your host, myself, Dr. Jay Resnick, and Dr. John Robertson. Practicing oral surgeons bring you the latest and greatest in pharmacology as it affects you in your daily dental practice.
Well, hello there, John.
Hello there, Jay.
There you
How
go.
are we doing? Yes, sir. Got
Good,
hit
good.
Unmute button. We're good to go.
Yeah.
All right.
Yeah. How are things in Mississippi?
Man, everything's good. It's starting to cool down now.
Yeah.
I know you guys are used to it out there, but it was just less than about a week and a half, 2 weeks ago. We were still having blistering heat.
Yeah, we were too, like 2 weeks ago, and then it kind of cooled down, and yeah, it's a lot cooler this week. It was beautiful over the weekend.
Yeah, it's good now, man. Everything's good. So
yeah.
Real excited about our show as always. 9 drugs got released this past month, Jay. 9.
I thought I counted 10. Well, we're only going to cover 8 of them.
Yes.
Because of time. But so let me cue up the slides here. There we go. And we'll get going. So we want to thank our 2 sponsors, iCore RX, which is part of iCore Connect, and they do e-prescribing. And of course, it's accessible from your office, from your home, from your phone. So they make prescribing much, much easier than it used to be. And then Fortune Law Firm, who are in the business of giving you a complete service as an advisor for you as a dentist, not only you're for financial, legal, retirement issues,
license protection.
Yeah, and how to protect yourself. So
Absolutely.
it's a great company. So anyway, there've been a few interesting things in the news.
You know, Jay, I like this little section because there's always going to be something about medications, you know?
Yeah.
And I didn't mean to cut you off, but it's just, besides telling everybody about the new drugs, there's always something else going on with the medication.
Yeah. Yeah. There's not always new things that are happening. And there are always issues that we have to deal with that kind of make life more complicated.
Yeah.
Let's see.
So typical, overdoses are still making headlines.
But what's interesting is over the last 10 years, rather than just, heroin overdoses or fentanyl overdoses, it's becoming actually a 50-fold increase in the use of fentanyl plus cocaine. And they're calling this the 4th wave of the U.S. overdose crisis. You remember there were 3 waves. The first one was when, when was that? In the 80s? When
it was in the 80s.
When prescription opioids were heavily marketed. And then as they got more and more expensive around, I think, the late 90s, the people who were addicted to narcotics and to opioids couldn't afford to buy OxyContin because it was like $5-10 a pill. And so they kind of moved back to heroin. And the rate of heroin overdoses went up exponentially. And then, of course, the 3rd wave started in, I think, 2013. And that's when fentanyl overdoses started overtaking everything else. And now we have this combination of fentanyl plus coke, which, has seen a 50-fold increase in the last 10 years from 0.6% in 2010. That's 0.6% of overdoses were due to a combination of these 2 drugs, where in 2021 it was more than 32%. That's a significant jump.
Yes, it is.
Yeah. So that's one interesting thing. Then the next one is ADHD drug errors among kids have quadrupled in the last 20 years. And so these are basically medication errors involving ADHD drugs. And, it could be that the medication was, inadvertently taken, or the kids got into it, into the medicine cabinet. Sometimes, mom gave the dose in the morning, and then dad didn't know mom gave the dose, and that happens every day. And then they end up building up a toxic level and overdosing. So that made the news too. Let's see, when did that make the news?
And then, of course, about if you're taking any CBD product, you might want to make sure you're telling your doctor for the possibility of any type of adverse reaction or adverse event that could occur with the medication he or she might be prescribing you.
Yeah. I mean, it's, CBD is generally considered safe.
Correct.
But it can interact with some prescription medications. And I believe one of them has to do with warfarin, Coumadin.
Yeah.
It can prolong bleeding. And so, again, and the thing with the CBD industry is it's really not regulated at all. And who knows what's in the compound that someone's taking.
That's right.
And so you want to be sure, make sure you ask your patients specifically, are they using, any cannabis products in any form? Same with CBD, because you need to know about that. Otherwise, you could have an adverse drug reaction that you were trying to avoid.
And then, of course, the next agent, Jay, we're talking about a new antibiotic that could help fight the resistant staph infections that we see in hospitals that take the lives of many people. Because,
MRSA.
MRSA.
Exactly.
That's exactly right.
Yeah.
So that's good to see. We've got a new player in the field that can actually help our physician colleagues fight this resistant staph.
Yeah. Yeah. I'd say like 25% of patients that get MRSA actually die within 90 days. Yeah. So it's not, it's a pretty serious problem.
It's a very significant problem. Yes, it is.
And finally,
last one.
Go ahead.
Oh, I was just going to say, it's interesting. We talked about CBD. Now we're going to talk about heavy marijuana can actually or may harm the heart.
Yeah. Yeah. And they've seen an increase in first-time cardiovascular events in patients who were otherwise fairly healthy, but were major users of marijuana.
So it'll be interesting to see where this goes, Jay, because, for how many years have we heard, it's safe and nothing's going to happen and stuff like that.
Yeah. Yeah. But when you're addicted to it and you smoke it every day or a few times a day, it can have significant effects on your cardiovascular system and your overall health, your pulmonary health. It's, nothing.
And we talked about it with oral surgery or just putting people to sleep.
It affects anesthesia. Yeah,
absolutely.
For sure. So those are 5 interesting articles we came across. So now let's move on to our first of the 8 drugs we're going to cover, and that is Aphexda, or Modixafortide, which is a hematopoietic stem cell mobilizer. And basically what it does, it's in combination with filgrastim or granulocyte colony stimulating factor, otherwise known as Neupogen.
Yes.
And what it does, Neupogen increases the number of blood cells that are created. And then the Aphexda mobilizes them to the bloodstream so that they can be easily removed without having to do like a bone marrow biopsy to get the bone marrow. And then they go through an apheresis process to multiply the number of cells they have. And then after the patients had chemotherapy, and knocked out the bone marrow, then they infuse these bone marrow cells back in. And it's used very commonly with multiple myeloma as well as other blood cancers.
Yeah, Jay, okay, we're going to talk about multiple myeloma here because we got some drugs about that. And we had some drugs last month as well that were first in class with multiple myeloma. Right. So again, I know we've said this before over the show over the last couple of years, but it's exciting to see these new first in class drugs coming out.
A lot of new drugs coming out. Yeah. And so the way that this drug works is fairly well. Actually, it hits a couple different enzyme systems or cell mediators.
Yeah, that CXC receptor 4 antagonist.
Right. CXCR4, and it's an antagonist, and then it blocks the binding of SDF1 alpha in addition. So it basically mobilizes the hematopoietic stem cells into the peripheral blood, where they're collected, multiplied, and then transplanted. So this is a lot more pleasant for the patients than having to have bone marrow aspiration in order to get the bone marrow cells that they need for the transplant after the chemotherapy. And the study it's a phase 3 study, which is a fairly big study, showed not only is it safe and effective, but 67.5% of patients using this combination were able to get to their blood collection goal of greater than 6 million CD34 plus cells per kilogram of blood with just 2 treatments, whereas for placebo it was only 9.5%. So that's a significant increase. And one of I guess kind of the big things to worry about with this, of course, is that there's a high incidence of anaphylactic shock, hypersensitivity reactions, and so they pre-med these patients before they give them these medications with H1, H2 antagonists, analgesics, and they just kind of monitor them very closely. And then the normal side effects, the common ones, are things like injection site redness, tenderness, all that kind of stuff that we experience when we get our COVID shots and flu shots. Yeah. So that's an interesting new drug.
And Jay, the other thing with multiple myeloma and dealing with the neutrophil count, that's something that we've got to ask our patients when they come in if they're having treatment, because they could wind up with a toothache. They could wind up with some form of a periapical infection. They're going to have treatment, and you need to know the absolute neutrophil count or the ANC before you treat.
Yeah, and that's why we repeat over and over again that you don't just take a medical history at the beginning when you first see the patient, and then maybe every other year. At every visit, you've got to ask the patient any new medications, any new health issues since I saw you last, even if it was a week ago.
And you'll be on the phone with the hematologist as well too, discussing your treatment plan, and then document. Please write this down, that everything that you discuss with that physician before you treat that patient.
Exactly. So you have it in writing, have it in your chart, because if it's not written, it didn't happen.
It never happened.
As we all know. Right. Okay. So our next medication is Ojjaara, or mormolltinib. Hey, quiet, you guys. Dogs are going mad. Which, as you can tell from the name, modulates the immune system.
We're dealing with the JAK1 and JAK2 again.
Good old Janus kinase.
Yes.
And not only does it inhibit JAK1 and JAK2, but it also inhibits activin A receptor type 1, ACVR type 1, for treating patients who have myelofibrosis with anemia. So what is myelofibrosis?
There it is, a very rare blood cancer. So, as we can see from the screen right there on the left side of the schematic, we have the healthy bone marrow, and we have the monocyte going to become an osteoclast. Then it does its resorption process with the bone, and then it just repeats itself for normal bone remodeling. But with myelofibrosis, that doesn't happen. You actually wound up with osteosclerosis.
Yeah, basically scarring within the bone and reduction in blood cell development, because there's the number of cells that can fit in the bone marrow space is reduced.
Yes.
Yeah. And so this is a new drug for treating this very rare cancer that inhibits both the JAK1, JAK2 pathways, as well as the ACVR1 pathway, and leads to a decrease in another drug called, or another substance called hepcidin, which is involved with reabsorption of iron and cross cell membrane transport.
And increased red blood cell production as well, too.
Yeah. So by blocking hepcidin, because it's elevated in myelofibrosis cases, that allows some recovery of the bone marrow.
Jay, one thing I thought about was very interesting. In their warnings, they said they labeled something MACE, major adverse cardiovascular events. Mm-hmm. I've never used that terminology before. No. Okay. Mm-hmm. So this is one of the warnings, MACE, MACE. All right.
Right.
So that covers a broad scope of things as well, too, that could occur cardiovascular wise.
Yeah. And remember, patients with myelofibrosis will have inhibited blood cell production. And so they're a much higher risk of infection. If you need to treat somebody, you need to keep that in mind and cover them with antibiotics, even for procedures that you might not normally prescribe antibiotics for.
Right.
Okay. So our next drug is Exxua, Gepirone.
How you like that? It's just another new drug for a major depressive disorder.
Yeah.
Gepirone. And it's in that class of azopirone antidepressants. And like I already said, it's being used for major depressive disorders.
Yeah. And, major depressive disorders really disrupt a person's life. They feel things like chronic emptiness, low, they can't feel pleasure.
Correct.
They feel worthless, emotionally and physically depleted. And many patients with major depressive disorder are suicidal. And so when patients are not improving with other medications, this is a new drug in our arsenal, or psychiatrist arsenal, to try to improve their disorders. But basically what it does is it modulates serotonin activity. And of course, serotonin is involved with mood and with dreams and sleep. And so it helps, they sleep better, but it also, by increasing their serotonin level, it increases their mood, which will hopefully get them out of that depression, along with therapy, and eventually maybe get them tapered off drugs or go on some other drug that's a little more mild.
But also, Jay, we have to be careful of how much serotonin accumulates in the body, because as we said, it does help with depression right there. Like you said, it's going to make the mood better, but if serotonin levels are too high, it can lead to like osteoporosis.
Mm-hmm.
All right. It can also decrease libido.
Mm-hmm.
All right.
Yeah.
But it does make you feel better. It helps the body to heal faster.
Right.
It stimulates areas in the sleep-wake behavior. And, this is almost like a last-ditch effort on someone who is suffering from this major depressive disorder. And, Jay, as well as I have, you've seen patients come in, they're on 4 or 5 of these various depressive medications.
Anxiety, antidepressants.
Yeah. They barely even function.
Yeah.
All right.
You wonder how they do. Well, the nice thing about this drug, Exxua, is it's a selective agonist of the serotonin 1A receptor. And so you don't get significant side effects. That's kind of the big bonus of this new drug.
That's right.
Is it's more selective, super selective, and doesn't have all these side effects. Or if they do, they're very, very minimal. And it's a once daily tablet. And the things that we need to worry about, though, with any drug in this class is something called QT prolongation, which we've talked about before. And this is, of course, the EKG readout of the cardiac cycle. And the P wave is the impulse going through the atria. And then the QRS is when that impulse goes down the Purkinje fibers and causes the ventricles to contract. And then the T wave is the repolarization. And if that interval becomes too great, what can happen is that you can have some arrhythmias. And one of the most common ones is what we call torsade de pointe, which basically means twisting of the points. It's a polymorphic ventricular tachycardia, which can then lead to ventricular fibrillation with a high rate of death. So we've got to be careful that these patients that are on these drugs have good cardiac monitoring.
So, Jay, let's point out something at the very bottom. The clinical feature of this arrhythmia is often syncope.
Yeah.
You and I have recently just done some webinars. We talked about syncope. All right. We all discussed half of the medical emergencies in dental offices are syncope.
Yeah. Very common.
What about the other half? Okay. All right. So if you happen to have this ROT phenomenon occur, okay, the first presenting clinical feature could be syncope. All right.
Yeah.
And it can be asymptomatic.
Yeah.
All right. How many times have we told you, colleagues out there?
Yeah. It could be asymptomatic in addition or cause a syncopal episode.
That's right.
Yeah.
You know, what do you do in 30 seconds when they don't wake up from, quote, syncope? What do you do in 60 seconds? You know, because this can degenerate into VFib. And if you don't do something quickly, all right, death is going to happen in your office.
Yeah. I mean, normally with syncope, we do the usual things, you know, O2, raise their legs, you know, cold compress. We always get them on the cardiac monitor right away.
Yes.
Take vitals right away.
Great point.
And of course, even before you get all the monitors on, if the patient is not breathing and pulseless, okay, then you immediately are going to start CPR and have someone bring your AED and go through your normal emergency protocol in the office.
And I want to say something, high quality CPR. Okay. I mean, effectively getting down minimum 2 inches all the way to 2.4 inches, 100 to 120 compressions per minute, high quality CPR.
And if you're doing high quality CPR, you're going to tire after 2 minutes.
Yes.
And so you want to make sure that your staff are all fully trained in
BLS
and maybe even ACLS.
Yes.
So they can help you with this emergency. You're not doing it all by yourself with your assistant standing around panicking.
Yeah. Because how are you going to maintain the airway if you're having to do CPR? You know what I mean?
Yeah. And there are a number of medications that are known to prolong the QT interval. A lot of antibiotics, analgesics, antihistamines, antifungal agents, even some corticosteroids.
Even ondansetron, Jay. And we use that all the time.
Yeah, for post-op nausea.
Yes.
Or we give it preemptively. Yeah.
Right.
And a lot of SSRIs, of which Exxua is in that class. Right.
And
so
look at the middle of the chart, the macrolides.
Yeah,
right
macrolide antibiotics. We use those, prescribe those all the time.
Absolutely.
Yeah. And oxycodone, if you prescribe that for pain. Ciprofloxacin. There are a lot of medications on this list that can prolong QT.
Yes.
And if the patient's already on one drug that does, let's say the patient is on
trazodone
or famotidine.
Yeah.
And you give them erythromycin. Or Zithromax.
Yeah.
You can increase their risk of this QT prolongation and Q on T phenomenon. So you've got to be aware. You always have to have your radar up. And that's, of course, why we always ask at every visit, any new medications, any new health issues.
Yes.
Yeah. Okay. So the other thing with medications that increase the serotonin level is what we call serotonin syndrome. And that's can be actually very serious, can cause some cardiac issues in addition to being very uncomfortable for the patient. I mean, they're sweating, they're shivering, can cause a tachycardia, altered mental status, neuromuscular activities like tremors or clonus, and it can even be life-threatening.
Yes. And Jay, I don't think we talk enough about this because, we always seem to focus on about the 24 different medical emergencies. I would say we could add this as the 25th one because how many times have you ever gotten a phone call? You did a procedure, they're on multiple medications. Mm-hmm. You wrote some of those medicines we just discussed.
Yeah, you wrote them for trazodone.
Yeah. And they call and say, gosh, I'm just shivering at home, and then I'm sweating, and my heart feels like it's just racing on me.
Yeah.
How many of our colleagues are going to think this could be a mild case of serotonin syndrome?
Yeah, and you want them to go directly to the emergency room.
Yes.
Yeah, and they're many times they'll be monitored. They may be admitted where they're going to use medications like benzodiazepines to kind of calm down some of the symptoms. And then medications to bring their blood pressure down, like nitroprusside or esmolol.
And the antidote for this is cyproheptadine, which is actually an antihistamine. Mm-hmm. All right, so they'll be given that in the ER when they get there. But that's a great point that you say, hey, these patients either call 911 or get them to the ER.
Yeah, exactly. Our next medication is Likmez.
Yes.
And I'm sure you recognize the generic name of this, metronidazole. And what is different about Likmez is rather than being in a pill form, it's a pleasant tasting, easy to swallow oral suspension.
Yes.
That can be used in a lot of patients that otherwise couldn't handle the bitter taste of metronidazole.
Right.
And so, in addition to treating anaerobic infections, metronidazole in medicine is also used to treat trichomoniasis and amoebiasis, which are parasite infections.
Yes.
And you can see how these parasites can basically infect, the liver, GI tract, lungs, and cause all kinds of problems. And having patients having an option, this liquid that patients that have difficulty swallowing can take, is a big benefit. I mean, you'd think someone would have thought of it earlier, but it took a little time until Likmez came out, and it was approved just last month. So, let me go back. So, John, let me ask you something. With metronidazole, I jumped the gun there. When we prescribe it to our patients, you prescribe it, right?
I do.
If I've got a patient that's got a long-standing or severe infection, in addition to amoxicillin or amoxicillin,
I'll piggyback it.
Yeah, piggyback some metronidazole. And what is it we always tell our patients?
Do not drink alcohol.
Right.
While I have you on this medication, please do not drink.
Right. Because what will happen?
You will get very sick.
Yep. This disulfiram-like reaction. Disulfiram is antabuse, which is used to keep alcoholics from drinking.
Correct.
And it causes some very severe symptoms, nausea, cramping, sweating, all kinds of bad things. And metronidazole is not the only drug that has been reported to cause this. Also, sulfonylureas, cephalosporins, griseofulvin, which is an antifungal, and of course, metronidazole. And the way that it works is that these drugs inhibit the aldehyde dehydrogenase. So acetaldehyde does not get converted to acetate, which then gets converted to CO2 and water. And so patient gets all these symptoms: nausea, vomiting, palpitations, blurred vision, etc., because the increased concentration of acetaldehyde in their blood. But what's interesting about this is, and I've been kind of got a headline in my medical newsletters that I get in the email every day. As it turns out, that's probably a myth, because what prompted the warning about metronidazole having a disulfiram reaction was one anecdotal case in the early 1960s with a heavy alcoholic who, of course, if you drink a lot, you're going to get nausea, vomiting, blurred vision, all those same symptoms. And I've looked at actually a number of papers. Let's see. Here's one that you can see. The myth that metronidazole and alcohol cause a disulfiram-like reaction. And here's another one from Antimicrobial Agents and Chemotherapy. The first one was from one of the ER journals. Fact versus Fiction, a review of the evidence behind alcohol and antibiotic interactions. As it turns out, these supposed interactions do occur sometimes, but they're really rare, and generally they're in patients who are binge drinkers or or drink every day. And so it's basically the conclusion of all these articles recently, like in the last few years, have been patients can drink alcohol in moderation, 1 or 2 glasses of wine or cocktails, while taking metronidazole without a problem. And,
okay, so here's what I need you to do, Jay.
Okay.
All right, we need you to solve this for the next month's PharmaDocs.
Okay. I'll do an experiment in the office.
I want you to be our disulfiram guinea pig.
Okay.
All right. So I'd like for you to get on metronidazole, prescribe yourself 7 days, and on about the 4th day, I'd like for you to have 2 or 3 old fashions and report back to us how you feel later on that evening.
Yeah.
All right.
Well, in that ER article, it basically said, we see patients in the ER all the time with various types of infections that we give metronidazole.
Absolutely.
And we know patients drink.
Yes.
How often do we see this reaction in our patients?
Well, they probably
pretty
drink
much never,
so much
unless they're heavy drinkers.
Yeah, the heavy drinkers, and then they get past the nausea and vomiting. They just pass out.
Exactly. So it's interesting. Something that we have believed for as long as any of us have been in dental school, is that this may just be kind of an old wives' tale.
Well.
So
I'm gonna still tell.
Okay, I'll do it if you do it too.
No, I came up with the idea. So you have to report back to the Pharma Nation next month.
And you're much taller than I am, so you've got to do double old fashions times 2 or 3.
Oh.
Okay. Right. So let's move on from Exxua to Ryzumvi, which is another drug that we are familiar with.
Yes, we are.
And basically, this is a formulation that is an alpha adrenergic blocker that is used for the pharmacologically induced mydriasis. And what, of course, does that mean? It means when you go to the ophthalmologist and they dilate your pupils.
Your eyes.
Yeah. So the mechanism of dilating your pupils, the mydriasis, is either by inhibition of the parasympathetic, or actually inhibition of the sympathetic nervous system, inhibition of the parasympathetic nervous system, which constricts your pupils, okay, and stimulation of the sympathetic nervous system, which increases the size of your pupils so that you can see light and see better in that fight or flight response. And of course, normally, different light levels. So what this drug is used for is after you've had your eye exam, they put a couple drops of Ryzumvi in your eyes and get your pupils back to normal. Because if you've ever had that done, you know how hard it is when you leave the office. Your eyes are really sensitive to the light. Things are just not as sharp, and it can last hours and hours and hours. So this drug blocks the alpha-1 receptors on the iris dilator muscles in order to allow reverse the mydriasis, reconstrict the pupil. Okay. Now, using our mydriasis, inducing it purposely to look at the eye, examine the eye, is not the only way this can occur. I mean, it normally occurs with bright lights, but there are other things that can cause either dilation, it can cause dilation of the pupils, like responses to if a patient has angle closure glaucoma, brain injuries, eye injuries. You can see dilated pupil. There's something called benign episodic unilateral mydriasis, recreational drugs, different medications, and then there's some, you see there, 80 syndrome, and basically what that is some idiopathic mydriasis in one or both eyes that they can't find the cause for it. It just, some people just have it. So it's kind of an interesting disorder, but the nice thing is when it's done therapeutically in the ophthalmologist's office, it's now reversible, or soon will be on the market, will be reversible. So you can drive home without having to wear 2 pairs of sunglasses. Okay, so let's move on to our...
That is going to be substantially significant for so many people.
Oh, yeah. I mean, you've had your eyes dilated before, right?
I haven't.
You haven't?
I haven't.
At your age?
At my age.
Yeah. I think I've only had it done once or twice, but yeah, it is. I mean, yeah, you're just really light sensitive, and your vision's just not as well focused for hours and hours. So until that wears off. So speaking of phentolamine, how in dentistry do we use this drug? And you are all familiar with this drug.
Yes. Or reverse.
Yeah, which is used for reversing local anesthetics.
That's right.
Patients who you want to...
But not in a local anesthetic toxicity emergency.
Right. It's only if, let's say, you gave the patient a long-acting local anesthetic like Marcaine, and you finish the procedure before you thought, you can reverse the effects of the local anesthetic. So it's not, I don't think it's used all that often, but it is something that is available to us.
Or in pediatrics as well too, because you don't want them to bite their lip or something like that.
Yeah. Adults do that too.
True.
Or burn themselves on their food because they can't feel. All right. So the next drug is Pombiliti, which, and actually the slide mentions Aphexda, which is a different drug. And what Pombiliti is a hydrolytic glycosomal or lysosomal glycogen specific enzyme combined with Aphexda or miglustat, which is an enzyme stabilizer for treating late onset. Is it Pompe or Pomp disease? I guess there's no accent.
No, I have it as Pomp disease.
Pomp disease? Okay. If it had an accent, accent aigu over the E, then it would be...
It'd be Pompe.
Then it would be Pompe. All right, good. I'm glad we clarified that. So this disease is a genetic condition. It's basically a glycogen disease where there is a problem in metabolism of some complex sugars like glycogen. And so the glycogen accumulates in the body cells because the patient's lacking the alpha glucosidase. And it can either occur, usually it's more severe in, there's a young onset at a young age. Those patients have much more severe symptoms, and they generally have a complete absence of GAA. Whereas the late onset, much more milder symptoms, usually onset in the 40s, and they have a decreased level of this GAA, alpha glycosidase, to break down the glycogen. So they don't build up as much glycogen as the early onset. So what this drug does, and here's some of the things that
it affects
Pompe disease can do. It affects a lot of systems. And what this drug basically does is it will, it's basically creates an exogenous source of GAA. So it binds to receptors on the muscle cell surface, and then it's internalized and transported to the lysosomes where it undergoes activation to GAA. So it increases the GAA level, increases glycogen metabolism, and reduces these symptoms. But especially with the young, early onset, all kinds, respiratory problems, respiratory failure, breathing disorders, sleep disorders, cardiac, which is less common in the adult onset or late onset, GI problems, difficulty in weight maintenance and growth, and all kinds of musculoskeletal problems.
Yes.
And so with
lot of systems, as you said, are definitely affected here.
Yeah. Well, glycogen is, of course, used everywhere in your body, and when it accumulates, it affects just about every organ system in the body. All right. So here is is this our last one? No, we have two more. Two more. Technegas, which is a technesium 99 carbon radioactive diagnostic agent. What it is basically they sort of it's made by, let's see, the Technegas is a carbon-based nanoparticle. It's been in use since 1984, and it's in widespread use. And what they do is they combine it with this ultrafine dispersion of radioactive labeled carbon with the technesium 99, and then they microfurnace it for just a few seconds at 27,000 degrees centigrade, and allows them to do what are called VQ scans, ventilation perfusion scans. And the most common indication for this is the good old pulmonary embolism that we all learned about in school. And so basically, as you know, an embolism or an embolus is a blood clot that frees and then lodges somewhere else. And in the case of a pulmonary embolism, of course, it's lodging in one of the big pulmonary arteries.
Yep.
And so it basically cuts off blood flow. And so patients, will have shortness of breath, tachycardia, all kinds of symptoms related to the fact that they're not oxygenating very well. So sudden shortness it's sudden onset. Sudden onset.
Sudden onset.
Yeah. And, we see it sometimes they used to see it a lot in post-op patients, which is why a lot of patients now after surgery, if they're going to be laying around, wear compression garments on their legs, or have what we call leg squeezers, sequential compression devices that basically, squeeze the muscles in the leg to prevent those blood clots from
referred to as TED devices.
Yeah. And this is also seen in patients who are on long-term flights, right? Like, cross the, 8-hour flights from LA to London or wherever you may be going, if they don't get around and move around. So that's why if we try to get patients moving around as quickly as we can after surgery.
That's right.
And we always tell people, don't sit in that plane seat for 12 straight hours. You got to get up and move around every couple hours. So the way a ventilation perfusion scan, so ventilation is V and Q is perfusion, and not perversion, but perfusion. And you can see at the top a normal scan. If you look at the perfusion, you can see that both lungs are completely perfused. And on the right, both lungs are completely ventilated. So that's what we call a VQ match, or match VQ. What happens in some other disorders is you get a VQ mismatch. So let's say there is a pulmonary embolus and it blocks off perfusion. Then you'll get an appearance like you see on the lower left, where there is an area at the top of the right lung that is not perfused, while ventilation stays the same. And again, you have a pulmonary embolism on the right, where you see another perfusion defect. Same thing, but with good perfusion. Actually, the one on the left is a perfusion and ventilation, since the top of the lung is not being perfused on the right, it's not being ventilated either. So that would not be a VQ mismatch, such as the one on the right is. But anyway, so this is one of the tests they do for pulmonary embolism. They look for VQ mismatch, where the lung is being ventilated but not being perfused. And then, of course, they get the patient on blood thinners right away. Sometimes if they're suspecting other clots, they place what's called what's the name of the umbrella? Basically goes in the inferior vena cava, and it's a filter.
It's a Greenfield filter.
Greenfield filter. That's
Greenfield.
Yeah, Greenfield filter. But they get the patients on anticoagulants, usually heparin, so they dissolve the clots right away. And then, of course, these patients who have had a pulmonary embolus are on Coumadin or other blood thinners for 6 months to a year, and sometimes they never get them off of them.
Or Jay, the blood thinner may not dissolve the clot. What it would do, since the clot now is, say, on the side of the artery wall, then eventually by thinning the blood, you can get the endothelial tissue to grow around it. So that's another thing that could happen as well too.
Yeah. And our final drug is Rivfloza. Or Nidosiran.
Yes.
And this is a drug that is directed towards small interfering RNA to treat lower urinary oxalate levels in patients with primary hyperoxaluria type 1. And oxalates are normal, natural compounds that are found in vegetables, fruits, nuts, and grains, and actually high in green leafy vegetables too.
Yes.
And they're also normally created by the human body as a waste product of these foods. And so primary hyperoxaluria 1 is a genetic disorder where there's an overproduction of oxalate by the body. So, of course, when you got too much oxalate, what does it do? It causes kidney stones, which can lead to chronic kidney disease. And so this drug works to lower the oxalate levels by decreasing an enzyme, LDH, hepatic lactic dehydrogenase, that is instrumental in the pathway of making oxalate. So it's usually an injection that's given once per month. And this was approved by the FDA because it was shown to reduce oxalate levels by 37%, and where the placebo group only increased or decreased oxalate levels by 12%.
So, Jay, this could help our kidney stone patients out there as well, too.
But especially the patients that have this genetic disorder.
Yes.
Yeah. Okay.
I'm sure there'll be an off-label use with it.
Oh, I'm sure. All right, now it's time for our medical emergency of the month.
The MEM.
Yeah.
And Jay, this could happen.
Everything.
This could, you got to in today's time, man.
Yeah.
This could happen.
You see the acronym, you just got a number. What the hell does the acronym mean?
Anytime, any day in the dental office. So let's give some little tips right here. Slurred speech, vertigo, dizziness, unilateral facial weakness.
What's happening? And you should know this one without a doubt. And that is either a stroke, or if it's just temporary, a transient ischemic attack, or TIA.
Because a stroke and a TIA are going to look like the same, except in a TIA, you recover in 24 hours.
Yeah, or sometimes even less.
Yeah, or
and
less.
If you have
24
a patient,
hours is usually the cutoff right there. It's not a long period of time at all.
And if you have a patient who says they've been having a number of TIAs, they are at extremely high risk of the next time stroking out in your office. So
correct, Jay. Very good.
Make sure that you have a consultation have the patient go see their physician to basically take a look at this, make sure they're on their blood thinners, because this is basically caused by a thrombotic phenomenon. Again, thrombosis that then dissolves. Whereas with a stroke, a full-on stroke, it can be either a thrombotic event or a hemorrhagic event, in which case you don't want to put them on blood thinners until you've had a CT scan.
That's right. So never, ever give a suspected stroke patient an aspirin. Don't do that. Okay.
Yeah.
But I tell you, the thing about what you just said, Jay, is so important for our listeners. If you're taking an adequate medical history and that person, I've had these little mini strokes, probably 3 or 4 or 5 in the last, 3 to 5 months. There's about a 15% chance of that person having a full-blown stroke in your office.
Yeah. Yep.
And so be aware of that.
What do you do? Well, first of all, you can't assume this is just a TIA. You have to think it could be a stroke. And the thing with stroke, with a thrombotic stroke or even with a hemorrhagic, is it requires very rapid evaluation and treatment. Otherwise, of course, it's going to lead to permanent damage. And so you're going to treat a TIA patient just like you're going to treat a stroke patient. The first thing you're going to do is call 911, get EMS activated, and put the patient on 100% oxygen. And then you're going to elevate their head because they can breathe. You basically want to lower the cerebral pressure and get monitors on them if you can. Record their vital signs every 5 minutes or so, and then get the patient ready for EMS and be able to give them, of course, the complete medical history, drug history, allergies, and exactly what happened. And the thing that's so important with a potential stroke is, when did the symptoms first begin?
Write that time down.
Yeah, write down that time.
Time lost is brain lost, and the emergency department needs to know what time this happened in your office, because they've got a window of opportunity to give a blood clotting buster called TPA. All right.
Tissue plasminogen activator.
Correct. And very important. They like to try to give it within 3 hours of the initial symptoms occurring.
Yeah. Yeah. So that's why you can't wait and see if the symptoms resolve. You have to call 911 immediately.
Yes.
Okay.
Do not send this patient home.
Yeah. All right. You guys aced our medical emergency of the week. So now is our shameless plug for some of the other things we do. As we mentioned before, on dentallearning.net, we have a pharmacology series called PharmaDent that covers in depth about, 16 categories of 15 categories of drugs that you need to know in that your patients may be on. And then
Jay, back up one time.
Okay.
All right. So I just gave a webinar last week on medical emergency preparedness. And 2 weeks before that, Jay and I just did a talk on medical emergencies as well. A lot of the post-webinar reviews are, we need something on pharmacology. Well, to all of you listening out there, Jay and I have done that for you. You don't have to travel anywhere. Of course, I'm being biased, but this is a phenomenal series right here. 15 different medications.
You can watch this from the comfort of your home, your laptop, with an old fashioned or two, as long as you're not taking metronidazole.
So the thing about it, you can go back over and over and over for the next year.
Yeah.
And this is only $99. Try to go hear somebody give a lecture on pharmacology. Yeah. Where are you going to find that person? And
I don't know.
And is that person a dentist like Jay and I? Do they work in the trenches every day like you and I? And this is dedicated to our colleagues to get you updated in pharmacology. And Jay sort of jumped the gun when he said 16, because we are working on the 16th medication category. But I'm telling you, this is everything you need to stay up to date with pharmacology. Yeah. This is mind blowing how good this material is.
Yeah.
I'm telling you.
Yeah, and we have other good material. Our dental office
Yes.
medical emergency simulation, or DOMES program, 4 different modules that teach you how to handle all 24 medical emergencies, broken down into 4 modules of 6. And again, this is only $99, and of course you get let's see, it's 2.5 hours of CE for only $99. And just as a general rule, CE is generally sold for about $100 per hour. So this is a real bargain.
And that video that Jay did, you have it for a year. You can go back and look at it over and over and over.
Yeah, and you can have guests over to your house, and put up your video projector to your computer, and lock the door so they can't get out, and show your friends and neighbors how to handle medical emergencies.
Yeah,
we have our other courses. I've got a course for responsible opioid prescribing for dentistry. There's one specific for California that meets the California requirements for 2 hours. And then there's a 3-hour one that covers the requirements for just about every other state. John just recently did an update on anaphylaxis and how to manage that. We did a webinar together called Patient Dies in Your Office. What happens next? It's a scary thought, but it's something you need to think about. And then pediatric and sedation and airway emergencies is another course that we've got online. And of course, then we have our live courses.
Yes.
John and I are directors of a couple of courses right now at Vesper Institute in Cincinnati, Ohio. It's a beautiful facility.
Gorgeous.
And in fact, we've got a course coming up in a couple of weeks on advanced emergencies and airway management with a skills station program.
First in class right there.
So it'll teach you not only, what to do, but how do you put in an oral airway? How do you put in a nasal airway? What if you have to put in an OPA or a pharyngeal airway or an iGel airway or, a needle cricothyrotomy? How do you do that? Because the time to learn how to do these things is not when you have an airway emergency in your office.
Right. And what about, do you properly know how to do BLS? You sure? Because at our course, you are going to have to demonstrate how to properly do that for 2 minutes at one station. And like Jay said, it gets very tiring. And even at our anaphylaxis stations, we're going to show you everything you need to do, because some of these emergencies that we're having at our skill station, we like to call them the 3-minute emergencies. It's 3 minutes to life or death. So you don't have much time to act, and we will get you ready. Promise you.
We will. We promise. And for those of you who are interested in bringing IV sedation into your office,
and hope you do.
And this program that we have starting in 2024, and I think we've got 5 courses scheduled for 2024 rather.
Yes.
Is more than surpasses the requirements for every state to get your moderate sedation permit. And think about what being able to provide IV sedation to your patients can do for your practice. Just think of the apprehensive patients that maybe don't even come in to see you because they're afraid to go to the dentist. I had a patient just about a month and a half ago. This big guy, he's like a personal trainer, covered in tattoos, and he had to have a tooth taken out, and he was scared to death. And so I had to use IV sedation, actually general anesthesia, to make him comfortable and get through the procedure. And then he came back again last week, and he had to have another tooth taken out. He goes, I think I can tough it out with laughing gas. Well, I got to tell you, I haven't seen a grown man whine and cry like that in a long time. And most of these patients won't even go to the dentist. They maybe had a traumatic experience as a child or even as an adult, and they just stay away from the dentist. And being able to provide IV sedation for those patients, or patients that you want to do, a long procedure on, maybe like a 2-hour restorative procedure, or bone grafts or implants. IV sedation is a great thing to learn and incorporate in your practice, and we're going to teach you how to do that.
And there's thousands of you out there that want to incorporate this, and you've thought about it. For some reason, you don't want to pull the trigger. Jay and I want to invite you to pull that trigger and come join us at the Vesper Institute. It's a whole different way of teaching. We want you to feel comfortable. We want you to feel relaxed. You're going to come out of there confident. You're going to come out of there competent. Like Jay already said, we surpassed the ADA guidelines for IV moderate sedation. And once you graduate from our program, you'll always be a part of this program. We've got some value-added benefits that we think no one else can come near to what we're offering here. And just a great group of people that are going to be involved in your IV moderate sedation education. Period.
And you're going to have a one-on-one mentor who is not a big, scary oral surgeon like we are, but a general dentist who does IV sedation will be your one-on-one mentor, which is pretty unique, because a lot of the programs, they go to a hospital and they learn from an anesthesiologist, and their 20 is doing 5 IV sedations themselves, and the other 15 they're watching someone else.
You're one-on-one with your fellow colleague, your general dentist. Okay. And I mean, we want you to be successful out there. Like Jay said, all right, what if you went and got implant training somewhere and that patient comes in, well, I want to be put to sleep. Well, you don't offer that. All right.
And you're basically going to do 20 cases of IV sedation where you're managing the sedation while your mentor general dentist is doing general dentistry. So it's a really unique program. We think it's it's going to raise to a level above all the other IV sedation programs out there. Again, it's VesperInstitute.com. So our next episode of PharmaDocs is going to be November 10th, of course, which is, remember, the second Friday of every month. Yes. We're going to talk about some new drugs that were approved this month in October, and of course have a new medical emergency to learn you about. Right? Is that how they say it where you live? We're gonna learn you.
That is not allowed on this channel. That is so unfair. I just can't. I hope you will do the disulfiram experiment. All right. Yeah,
let's do it together.
We're going to learn you over here.
We'll do it together in Cincinnati. How's that? All right. Sounds great. So good night, everybody, and good night, everybody. Hope you have a great weekend, and we will see you next month.
Thank you.